becoming more common because of many viral infections, especially dengue presenting with thrombocytopenia. To discuss this topic, we have Dr. S. Basi, Professor Emeritus, Internal Medicine, Sri Gogula Medical College as the chairperson. I invite you, sir, to the dais, and over to you, sir.
Matthew Thomas. Good evening. Let me thank the organizers for giving us honor. It is a very pleasant experience to chair the session where Professor Matthew Thomas is a speaker. We are classmates. He was in Trivandrum, I was in ILP for most of the time. Thrombocytopenia is now very common. The commonest is a short febrile illness, virus, lepto, scrub and so on. And then there are numerous other conditions, including malignancy. I have no intention to encroach on to the speaker's topic. He is a very good academician, close friend of mine, very good teacher, very good clinician, and his special interest is in hematology. Now the floor is open for you.
A very good evening, respected chairperson, my classmate, Dr. Basi, all the senior members of the IMA, and all the delegates. First of all, I should thank the organizers for allowing me to speak on a very common subject which you can find almost every day in your practice, a decrease in the platelet count. And every specialty may have a situation at least once in a week with thrombocytopenia, patients with thrombocytopenia. So I am just given 15 minutes, so I'll be going very fast. Platelets maintain the circulation by hemorrhagic control after the endothelial disruption. So that's the main function of the platelets. More have been found out how the platelets act. The platelets act, this is the endothelial cells in the blood vessel, and there is a zipper-like machinery which is helped by the platelets. There's a close contact or communication between the platelets and the endothelial cells. So this zipper-like machinery helps the platelets or the blood cells to come out of the cells. That's how it is maintained. When the platelets come down, this zipper-like machinery has got dysfunction, and then the platelets come out, the RBCs come out. So this is what is happening. So the intercellular gap becomes more and blood comes out through the blood vessels. So these are recent researches by which how does the platelets and the endothelial cells act. And now we come to the subject of platelets. Normal count, as you know, is between 150,000, 450,000. And the thrombocytopenia depends upon the number. So below 100,000, you just call it thrombocytopenia. It becomes severe when it is less than 20,000, and very severe when it is less than 10 or 5,000. And the important danger is bleeding manifestation, and the most important complication that the doctor does not like is the intracerebral bleed. This is the megakaryocytes, one of the largest cells in your body, from which platelets is produced, and you can see the platelets being budded off from the periphery of the cytoplasm, and the whole cell disappears after that. This is, you can compare the size and with the other cells in the bone marrow, it's one of the largest cells. These are the platelets in the periphery. It may occur as clumps or as individual. So this is how platelet looks in the periphery. Thrombopoietin is a very important enzyme, a hormone. You can call it a hormone just like erythropoietin, and it is synthesized in the liver, and it acts on the thrombopoietin receptors, and it increases the platelet count. It's a small study done in the KIMS where we find that people having decreased platelet count of thrombocytopenia, about 13% of the outpatients and about 28% of the inpatients. Clinically, thrombocytopenia may just remain asymptomatic, and it may be accidentally detected because when we were students, there were only HB, hemoglobin, TC, ESR. This is the only investigation that we used to do. But now automated counters are there, so any person can look at the results, they print out and find out that he has got deficiency of the platelets or the decrease in the hemoglobin. So it is becoming more, they are able to find out and come to a doctor. That's what's happening. So we find asymptomatic situations where the patient does not have any symptoms. It can result in superficial bleeding, skin and mucous membrane, especially in females with severe menorrhagia. That's one of the presentations. And rarely you have intracranial bleeding. This petechiae and purpurae, superficial bleeding, ecchymosis, gum bleeding, and sometimes they can present initially as a subdural hematoma. This one of the papers we have presented where a few cases, 4 or 5 or 6 cases presented first time with a severe thrombocytopenia with the SDH. An important thing, they were not subjected to any surgery and they recovered spontaneously, the hemorrhage being absorbed. Mechanisms of thrombocytopenia is a decreased production, an increased destruction, or a sequestration by the spleen, or there can be a combination of the decreased production and the increased destruction in ITP. Causes of thrombocytopenia, infections account for a good number, including dengue, septicemia, immune destruction. Classical example is immune thrombocytopenia. Old term is removed. There is no more idiopathic thrombocytopenic purpura. It is just called immune thrombocytopenia. And in SLE, non-immune destruction in microangiopathic hemolytic anemia, hypersplenism, a decreased production as in classically in aplastic anemia, bone marrow infiltrations, and there are inherited conditions which are rare. Immune thrombocytopenia, there is immune destruction of the antibodies, but later now we know that there is a decreased production because the antibodies also inhibit the megakaryocytes. So there's a decreased production and also there's an increased destruction. It can present an acute and chronic form. There are 2 age groups, 3 age group you can say. In children there is immune thrombocytopenia, adolescents, and then people after 65 years of age. Diagnosis of ITP is purely by exclusion, and it is said that it's a isolated thrombocytopenia without any cause. So all the other cell lines will be normal, and that is why only the platelets are affected and decreased. So that is how we diagnose an immune thrombocytopenia. I told you, children it can happen, and nowadays people are refraining from treating them, and a natural recovery is expected, but we do treat acute ITP in children. There's a difference between children and adolescents or adults. In children, 90% of the ITPs are curable, whereas in older people or adults and older people, it becomes chronic and only 10% get a cure and 90% continue thrombocytopenia throughout their life. Coming to the different causes, we discussed about infections. One of the commonest infection is dengue fever. We have seen platelet count even below 5,000. But now the idea will be not to give platelet transfusion unless there is a bleeding. So even in ITP, the same rule holds good. That's a new rule. So only if there is a bleeding, you try to give the platelets, otherwise no platelets. If the patient is not bleeding, no platelets at all, no platelet transfusion. Sepsis also is another infection where you get thrombocytopenia. HIV is another example. Drugs, especially the chemotherapeutic drugs, then heparin also is another drug which can cause thrombocytopenia. Splenic sequestration. Any condition where there's a large spleen, the spleen started to see these platelets as abnormal and destroy the platelets. And any condition where there's a large spleen, you can get a thrombocytopenia. The classical condition is chronic liver disease, portal hypertension, tropical splenomegaly, and chronic malaria. Pseudo-thrombocytopenia is a rare situation where the patient is perfectly normal and his platelet count is normal, but an anticoagulation abnormality where the anticoagulation agglutinates the platelets and it is found low. But if you take a finger prick and see the platelets, they are normal. Other causes are uncommon, inherited causes, acute leukemias, bone marrow infiltrations, all these are uncommon conditions. Radiation, gestational thrombocytopenias, massive blood transfusions, all these are causes. This is a large splenic angioma producing thrombocytopenia. Now, clinical and investigational approach, a good history is very important. The history of drug intake, history of infections, family history, all these are important. Physical examination is very important. Splenomegaly usually excludes an ITP. In ITP you do not find, but bone marrow infiltrations like leukemia producing thrombocytopenia, the spleen will be enlarged, the liver will be enlarged. No findings in pseudo thrombocytopenia as we said, and you start off classically with a complete blood count. This is the basic investigation and a blood smear. So this will be enough to make many of the diagnoses, inflammatory markers, ANA screening, and it goes on like HIV screening, abdominal ultrasound. Bone marrow studies usually not necessary now. They say you can straight away start treatment, but we do not want to miss any case. So we almost do bone marrow in most of the cases who are symptomatic. Special investigation, upper GI examination, dengue. Then coming to the treatment of thrombocytopenia, different causes, you assess the severity, very important. The clinical, if the patient is completely clinically normal and the platelet is about 50,000, you don't start any treatment. So it depends upon the severity of the disease, determine the cause and the urgency of treatment, especially when there is a bleeding and the platelet count is low, say below 10,000. Or if the patient is symptomatic, whatever be the count, if the patient is bleeding, even if it is a high count, you start treating the patient. And in ITP, we usually start treatment only when the platelet count is less than 30. Or if there is a bleeding, you start it before that. And a patient with an acute ITP, you have to start immediately treatment. The ideal drugs will be intravenous immunoglobulin, methylprednisolone IV, dexamethasone. I told you about platelet transfusion. If there is bleeding and a desperate condition, even we use factor 7A. Acute children in acute ITP in children usually left alone, but these drugs are said. Chronic ITP is very important that the patient may have a low count, and one should be clear that they do not treat the platelet count, but they should treat the platelet. If the patient is completely asymptomatic, no treatment or very low dose of drugs, because in large series it has been found the final morbidity and mortality is mainly due to the side effects of the drug and not due to the disease. So there is a new concept that when you treat patients with ITP and other conditions, when the patient is better, you stop the drug and you give a drug-free remission for a long time. And when again the platelet count comes down, you start treatment. So we are just forgetting what is called a maintenance treatment in ITP and all that. So when the patient is in remission, you stop the drugs so that the side effects of the drugs may be avoided. So these are all different methods to use, treat chronic ITP, and splenectomy is a very good treatment for refractory cases, and it is almost a cure, a long drug-free remission you can get with splenectomy. So that is not advised because we have got newer drugs. So splenectomy, we try it when there is no other go. There is no other, then all these drugs are being used, and we do not know still which is the best drug. But a breakthrough has happened in the last decade with the introduction of thrombopoietin receptor and agonist, which can stimulate the megakaryocyte to produce more platelets. So on this one side, the platelets are destroyed, but the other side there's an increased platelet production so that the platelet count is maintained. The two drugs which we have now is, one is L-thrombopag and the other is romiplastin. So one is an injection, one is a tablet, and it has worked wonders. We are very happy to treat now patients because these drugs show a very good response, and the expensive drugs, they have come, the expenses come down because Indian companies have started producing this. And thrombocytopenia may be seen in pregnancy as in gestational thrombocytopenia, which is a mild type of thrombocytopenia or ITP occurring during pregnancy. So that has to be treated as any other situations, but drugs will have to be carefully selected because some of them may produce teratogenic effect. I think with that, I finished the talk because I want more questions. That is why I thought of stopping the talk and then allow discussion. So all of you may be having many cases. So all your doubts can be clear.
Thank you, Dr. Matthew Thomas, for the, as usual, very clear, crisp presentation, and finishing 15 seconds earlier. Now, before it is the question, I think as a privileged chairperson, I have not to comments and few clarification. The comment is, it's a reiteration or re-emphasis that dengue fever is a commonest cause of severe thrombocytopenia, self-limiting, self-curing. Unfortunately, many institutions, lot of platelet transfusion is given without indication. That has to be because no blood transfusion or blood powder transfusion is absolutely safe. If you are doing only the screening test for diseases. That has to be re-emphasized. Matthew has already mentioned it, but the second one comment, I had a patient with dengue fever, platelet count was 35,000, gum bleeding. Then I closely looking at the gum, there was gingivitis. Got immediate opinion from the dentist, gingivitis was with local management, no need of platelet, and the patient improved. So the message there is, when the platelet count is well above the usual level for spontaneous bleeding, that is less than 20,000, look for other causes also, because that may be especially for gum bleeding. Then I have a few queries. One, in CLD with splenomegaly, in addition to the hypersplenism, is there a autoimmune, immune-mediated mechanism? Second is some of these ITP, immune thrombocytopenia, especially in young female, it may be the first manifestation of SLE. We have seen it. Is it possible that splenomegaly can be there? Because classical ITP, splenomegaly is absent. The third one is, it's just a many little funny question, but normal platelet count is mentioned always as 150 to 450. And thrombocytopenia, most of the standard literature, whether it is US, UK or Indian, it is said as less than 1 lakh. If somebody asks, a student asks you, what will you call when it is 1.10 lakhs or 1.2 lakhs? What terminology will you use?
So the chronic liver disease, the mechanisms are different. Mainly it is due to the large spleen, and in a liver disease, the thrombopoietin production is considerably reduced. So that is another very important cause of thrombocytopenia. And usually treat because the production is normal, bone marrow is normal. So only if they have bleeding and severe thrombocytopenia, we treat that. The second was,
That,
yes, which one? They develop cytopenia. But if
Yes.
the platelets are very low, you have to do something.
young female SLE first presentation as
So
ITP
we
only.
have got many cases of ITP which I have treated at the young age of 8 or 9, and they continue, and after 10 or 15 years they develop SLE. This is a very common situation, not very common, but occasionally we find patients switching over to another immune disease, autoimmune disease, and sometimes into hypothyroidism. Many of the females can shift. So it is probably a dysregulation of the autoimmune system that tips them onto other diseases.
Last is platelet count 1.1 lakh. What term will you use?
What?
1.1 lakh is a platelet count, or 1.2 lakhs. What
Yes.
terminology, what label will you put?
We'll have to use thrombocytopenia, but it's probably very,
Because
very
the
mild.
books only says less than 1 lakh, and normal only says 1.5 to 4.5 lakhs.
Yes.
Why it is not? Why not we revise it?
Why not?
We revise it less than 1.5 thrombocytopenia.
So
And
it
like
is-
normally it's 1 lakh to 4.5 lakhs.
It is thrombocytopenia, but they have found when you see the plot of the standard deviation, you can come down to about 140, and they have followed these patients for many decades. They have not had the disease.
Actually, the normal reference range is for 95% of the population.
Yes.
2.5% will be above the reference, and 2.5 will be the even
That's
Davidson. There is a curve in the middle.
That's
Now the topic is for discussion, questions and queries from the.
Patient who has a stent and then on a DAP, dual antiplatelets with thrombocytopenia.
You have to increase the thrombocytes, platelets by all the treatment that we have, and then give them the double antiplatelet or single antiplatelet. So we have got several patients with coronary artery disease with ITP developing an acute coronary event. Their platelets will be low, 30, 40,000, but if they didn't have the coronary artery disease, they will not be treated. But here, we'll have to give good drugs, take it above 1 lakh, and give aspirin and clopidogrel.
Very often we see in pediatrics, ITP cases of thrombocytopenia, 5,000, 6,000. With immune thrombocytopenia with 5,000, 6,000, absolutely with no other symptom. We are afraid to send them home actually, and if you give immunoglobulin 1, they may not be able to afford it. Number 2, they will come back after 21 days with the same count. Now, many times in the Gulf, we used to give steroids, but there is a criteria given by the British where you can give steroids without a bone marrow. But our teaching is we never do it. What about you?
I think you are correct in both ways. Now, the correct guidelines, if you are sure that is an immune thrombocytopenia, not involving any other cell lines and not having any other disease, we need not do the bone marrow, you can straight away start treatment. That is the guidelines, but we are also in the same boat, so we do the bone marrow.
Bone marrow, yeah, that's what happens.
That's what.
Because there are definite British guidelines which says if there is no splenomegaly, no bone tenderness, no other cells are involved, and the patient have a platelet count of 5,000, and if you want to give steroids, you can. But nobody does it. At least we pediatricians will never do it.
Yes. We have missed cases of acute leukemias.
Yeah, that's
There's
why.
no doubt about that. Back, yes. I didn't hear the question.
So the drugs in the market which are supposed to increase platelet count, do they have a role?
Yes, that is why we were telling about the newer drugs. The most important ones are the L-thrombopag and romiplastin. Romiplastin is given by an injection, 250 micrograms subcutaneously, very effective. But it has to be given every week. And by this, if the platelet count increases to above 1 or 1.5 lakhs and patient does not have symptoms, we stop everything and see. That's the new guidelines. Yes, ITP is the indication. Is the indication. And L-Trombopac, it is the indication. Very good tablet. Pediatrics 25 milligrams and adults 50 milligrams. It was costly. Each tablet was costing 2,000 rupees per tablet. So 10 tablets 20,000, 30 tablets 60,000. But the Indian companies have started. There was a lot of fight in the court, and their period was over. So the patency is over. Now we have got L-Trombopac for 400 rupees.
As already we are.
So that is wonderful.
As we are already very late. I think
So
we will-
one more question. Sir.
That is the last. That's the
Yes,
last.
there is a papaya leaf extracts. Do they increase platelet?
I think we should not do anything with that unless it's clinically proved.
അത്
You
papaya
do a clinical trial, you give papaya leaves to 10 people or 50 people with thrombocytopenia, placebo for the others. If there is an increase in the platelet count, find out what is the chemical which is responsible. And then you say that clinical
അതിന്റെ
trial.
പ്രോബ്ലം എന്ന് വെച്ചാൽ it can be used as an insecticide. Papaya leaf extract. It has got lot of alkaloids which can be. I have seen ulcerations, gastritis, vomiting.
Not clinically
Not
proved.
to be used. Not to be used. We will.
Pomegranate is also used, but we have no
There is no data to show that any of the.
evidence-based. There is no evidence-based medicine.
Like
So-
short fever, dengue fever, like it is 100% it will recover. So you cannot say unless you have very properly conducted studies, you cannot say.
Yes.
I think as we are running very short of time, already very late, we will close the session. Thank you, Matthew Thomas.
Thank you.
Thank you, sir. I request Dr. Yamini Tankachi to present a memento to Dr. Matthew Thomas.